Welcome everyone to the Deane Center for Cognitive Health webinar. Let's just give another minute or two to get everyone else to join and sign on. Okay. Does it look like we should get started? Hands up, my team. Okay. Welcome to those who joined us a year ago in person at the Harvard Club and to those joining us today online. Thank you all for coming. First of all, I'll introduce myself. I'm Dr. Jane Martin. I'm an associate professor of psychiatry, secondary appointment in neurology, and I'm the director of the Neuropsychology Center and also the training director of neuropsychology fellows, interns, and externs. Just a quick thing about the Neuropsych Center. We conduct neuropsychological evaluations, that's cognitive testing, to assess someone's cognitive functioning and provide this important piece of information in the process of diagnosing and treating a patient with cognitive decline and/or a dementia. Common referral questions are, is this normal aging? Is it just depression? Is it something more, mild cognitive impairment? Alzheimer's, some other neurodegenerative disorder, other dementia. The Deane Center. The Deane Center is in the Department of Neurology, and it's something very, very special at Mount Sinai. It takes a village to borrow a phrase, but it takes a village to navigate a neurodegenerative disorder, such as Alzheimer's and the other dementias. Unlike many other areas in medicine, which are typically very siloed, the Deane Center truly has an interdisciplinary and interdepartmental approach, which is exemplified by today's team who you'll meet today on the webinar. We have speakers from geriatric medicine, neurology, neuropsychology, psychiatry, and research. We all interface with each other, bringing our each special expertise to care for patients and their families. I also want to give a shout out and a thank you to the Deane family for making all of this possible. So, before I introduce the panelists, we have two special panelists today. Dr. George Nassan is going to share some updates since our last event last year in person. And then we'll hear from Dr. Audrey Chun, geriatrician, a little bit later. George?
Yes, welcome everybody. Really happy to be here and thank you for all those who joined. Just wanted to share some updates since last year. Some of you may know me from coming in person last year. For some, I might be new. I'm the co-director for the Deane Center along with Dr. Audrey Chun. We've been really happy over the past few years to be able to provide care in all of its forms, for people living with dementia. And we have built a program that is quite interdisciplinary where people can receive a one-stop shop, sort of all of their care in the same place, whether it is the neurologic needs, psychiatric needs, social work, so on and so forth. We've increased the number of patients that we're able to see since the inception of the center back in 2020, 2021, threefolds. So in 2024 alone, we were able to see close to 2,000, more than 2,000 unique patients throughout the year. We have also added a few parts to our program, which we're very excited about. We are now one of about 380 centers all over the United States that are designed as Guide Center from the Center for Medicare Services. Guide stands for Guiding an Improved Dementia Experience. And so this is a program that is available for people with straight Medicare, where we can provide comprehensive care to those living with dementia. And we're very excited, to bring that to life. We also continue to provide training for neurologists, psychiatrists, or geriatricians that are interested in becoming dementia specialists. We have a fellowship that is ongoing, and we were able to also secure some funding, for that fellowship, which we didn't have before. We are engaging in multiple, research projects. A really exciting one that has started, this past year is about the early detection of Alzheimer's disease via utilization of blood biomarkers, which Dr. Fanny Elahi, who's one of our panelists, will talk about in a little bit. And we were able to add a few new faculty and personnel to our team. We have a new physician assistant, a neurologist, that he trained with us and started in July. We are currently extending an offer to a new neuropsychologist. So we're really excited about the team continuing to grow and providing, more care for our patients, especially that we have a really long wait list, which we wish we didn't have, but there's a really long wait list of people who want to see us, and we want to increase our capacity to be able to provide this level of care to all patients who need it. We have about 1,400 patients, awaiting appointments with us, in addition to the unique patients that we already see that I spoke about earlier. So really excited for this program today, and I'm going to turn it back to Jane.
So I'd like to back up and actually give you all of George's titles here and what he does. He's pretty busy at the Deane Center. He's the co-director of the Barbara and Maurice Deane Center for Wellness and Cognitive Health. He's the co-chief and medicine director of the Division of Behavioral Neurology and Neuropsychiatry, and vice chair of ambulatory operations and quality in neurology. Dr. Audrey Chun, who some of you met last year, and she will speak to you in a bit, is the director of, again, the Barbara and Maurice Deane Health Brain Initiative and co-director of the Barbara and Maurice Deane Center for Wellness and Cognitive Health. She's also vice chair for clinical services for the Brookdale Department of Geriatrics and Palliative Medicine. So I think the next thing is that I should introduce the two panelists. So we have one focused on research and one focused on clinical services to support caregivers. So first we're going to hear from Dr. Fanny Elahi. And Dr. Elahi is the director. She has a lot going on as well. I'll add my 2 cents at the end. Dr. Elahi is the director of the Fluid Biomarker Research at the Barbara and Maurice Deane Center for Wellness and Cognitive Health, and co-director of the Biomarkers and Genomics Research of the Mount Sinai ADRC, that's the Alzheimer's Disease Research Center, as well as associate professor of neurology, neuroscience, and pathology, molecular and cell-based medicine at the Icahn School of Medicine. Fanny's area of blood biomarkers, there's a lot happening in that area, so welcome.
It's a pleasure to be here with you. So Jane, do you want me to talk about my research in a few words now?
I think that people need to know that there is a new blood test available to test for AD and what you're doing to really expand on that.
Sounds great. It's a pleasure to be here. I'm a behavioral neurologist like George. I see patients with various kinds of cognitive and behavioral changes, and my research passion is in developing companion diagnostics so that we become more precise sooner in the process of the diagnostic workup. Ultimately, my dream is for us to be able to detect every single pathology that affects behavior and memory, executive function, at a stage where these symptoms have not yet presented, but the pathology has begun. Early detection has been really essential for game-changing treatments of cardiovascular disease. It's been absolutely essential for prevention of death from cancer. And now that we have some new tools, and we'll discuss them in more depth in a bit, I think it's become within reach to develop these incredibly important diagnostic tools for our diseases. And there's one that's in clinic, and we'll talk about that again in a little bit, but there's a lot more underway. So I'm very excited about the few years that we have ahead of us.
So, Dr. Elahi, what is happening really at Mount Sinai to advance the early detection of Alzheimer's and other neurodegenerative disorders?
One of the studies that Dr. Nassan alluded to, which is called DAC, an acronym for Davos Alzheimer's Collaborative Project, is a worldwide international collaboration. There are 8 sites, and we are one of them. 4 of them are in the United States, and 4 of them are spread around the world, where we are implementing the blood biomarkers for Alzheimer's disease and brain degeneration in clinic. It means that individuals coming through the Deane Center or geriatrics clinics will be able to in the first instance possible, get a blood test that gives them the probability of actually harboring Alzheimer's disease neuropathology. This is game-changing because, as our audience may be aware, we needed PET scans. These are radioactive ligands and imaging, quite expensive, difficult to schedule, or lumbar punctures, which are really not pleasant. So this blood test is truly game-changing, and we can talk about this again more in detail in a bit.
Let me ask you at least one more question. How will early detection facilitate the development of new treatments to prevent dementia and have an impact on disease and really the lives of patients and their families?
To answer this question, I need to explain one really fundamental principle, that the problems, the pathologies that eventually lead to the development of symptoms such as memory changes, depression, anxiety, changes in behavior, all of the symptoms of dementia, start way before symptoms arise. We now know through longitudinal studies that up to 2 decades, 20 years before someone presents with symptoms to get a workup, we can start detecting traces of Alzheimer's disease pathology in their blood. And what that means is that we all know that we can't grow brain cells. We cannot really reverse the degenerative process. Once the degenerative process starts, all of the treatments, including anti-amyloid, could slow things down, and that's already great, but we can't stop it fully, and eventually people will decline. But we think as a field that if we detect it really early, it will be similar to in situ cancer, where you could potentially really implement game-changing treatments and actually prevent someone from developing significant symptoms. I have to add that right now, in the first phase of this study, we do need some symptoms to be present. So either the individual needs to be worried about the changes that they're experiencing, someone else needs to be worried about them. We are not yet implementing these tests for people who just have a family history, or are just worried. But I think that's where it's going.
Yeah, great. So this is a quickie. How can we accelerate this work to have real world impact, at least within the next 5 years, let's say?
Do you want my real answer?
Yeah.
Money, funding. I think we have the tools. We have the multidisciplinary setting that is ideal for this kind of study. And we need funding. The funding that we received from Davos Alzheimer's Collaborative really potentiated this incredible study, but there's a lot more to do.
Sounds good. I'd like to introduce our next panelist, Dr. Allison Applebaum. Wait, hold on. I have a whole description of her as well. Hold on. Wait a minute. I'm seeing it. Well, she's the director of the Stephen L. Baum Family Center for Caregiving and professor of geriatrics and palliative medicine at the Icahn School of Medicine. So now I want to add, she's new to us. She's been here about a year and a wonderful new addition, both as an expert in her area, but also in terms of the treatment of patients and families. She comes to us from Sloan Kettering, where she was for 15 years, and she founded the first targeted psychosocial program for cancer caregivers. So now this new center at Mount Sinai, which is in the Department of Geriatric Medicine, which also serves the entire Mount Sinai health system, is here to support dementia caregivers. So Dr. Applebaum, give us an overview, of the work and care that you're providing.
Sure. Thank you so much for having me, and it's such an honor to be here. I have the great privilege of leading our Stephen S. L. Baum Family Center for Caregiving, which is a home for caregiving science, and it's a home for caregivers, the parents, partners, children, siblings, and friends of patients within the Mount Sinai health system. As Dr. Martin shared, I'm relatively new here. I've been here for a little over a year, and before was on faculty at Sloan Kettering. And early on in my career, I'm a clinical psychologist by training. I realized that healthcare was increasingly relying on family caregivers to shoulder tremendous responsibilities without actually providing those caregivers with training, education, and support. I also realized early on, despite the fact that the scientific literature had already very well documented distress in caregivers, there were no targeted support services for caregivers in any cancer center or healthcare system in the country, which is what inspired me in 2011 to found the Caregivers Clinic, which was the first targeted service of its kind to support family caregivers. I'm so thrilled to be here at Mount Sinai to expand the efforts beyond oncology and to support caregivers of patients with all chronic and life-limiting illnesses, disabilities, and mental health challenges, with a real focus on the neurodegenerative diseases. Our Alzheimer Center has 4 key components to it: clinical care, teaching, research, and advocacy. What I want to focus on right now is our clinical care component, our caregiver support program, which has deep ties to the Deane Center. This is a mental health care program for caregivers. We provide individual, group, family, and couples therapy, as well as medication management. And as I said, we do partner deeply with Deane. In fact, as of today, over 60% of our referrals to our caregiver support program, meaning over 100 caregivers, have been referred to us from the Deane Center since we opened in January. I should say that we know from the literature, from my own experience clinically, my colleagues, that diagnostic rates of mental health challenges, anxiety, depression, trauma, are actually often higher in caregivers than the patients for whom they provide care. And we know that without support, the distress that caregivers experience will just increase exponentially across their caregiving experience and negatively impact their ability to provide high quality care for patients. So in our Alzheimer Center, we strive to provide support to help to give caregivers the skills and tools and support they need to feel prepared for caregiving and to be able to take care of their loved ones without great detriment to themselves.
So let me ask you a couple of questions. What are some reasons that caregivers might come to the caregiver support program?
There's many reasons why folks come to us. I'm going to give you 4 of the most common categories of reasons why people reach out. The first being managing anxiety, managing uncertainty. For those of you who are, I was going to say caregivers in this Zoom room, but humans, all of us struggle with sitting with uncertainty. And certainly for caregivers, not knowing what the next year or month or week or day may bring can be very, very difficult. So we give caregivers the tools they need to sit with that uncertainty. Secondly, many caregivers come to us for support around communication, how to communicate more effectively with their care partners, the patients they're caring for, and how they can communicate more effectively with all of us, the healthcare professionals. And increasingly, I should say, we are asking caregivers to take a lot of responsibility for healthcare communication, especially in the setting of neurodegenerative diseases. A third reason is that caregiving never happens in a vacuum, right? It's always superimposed upon so many other responsibilities, including paid employment, perhaps childcare, and everything else we have on our busy plate. And so helping caregivers to recognize that they only have so many hours in the day and how they can navigate their new responsibilities while also making time for their own self-care is very key. And then finally, I would say the other driver of referral is addressing what I would call existential distress. This is a fancy way of saying the distress that we experience when we realize that we are human, that we are mortal, and that all of us will not live forever. And certainly this distress is prominent for caregivers. And so we give a space for caregivers to process that existential distress and help them to move forward one step at a time.
A lot. What does a typical course of care look like?
So there is no one size fits all course of care because every caregiver is unique, as are their needs. That said, to begin care, every caregiver will have what is called a psychodiagnostic interview. They're going to spend about an hour with one of our staff members and talk about how they're doing, their history, if they've been a caregiver before, if this is their first time. So we can really understand what the challenges and concerns are and develop a treatment plan, a plan of care. That plan of care could be just 3 or 4 sessions to focus on a specific concern, like I need help communicating with my husband, for example. Or it might be, I've been really struggling with depression. I'm really struggling with low mood in the setting of caregiving, and we might establish a longer term goal of care. We revisit these goals of care every few months to ensure that the care we are providing is really responsive to caregivers' needs. I'll also say that while our work is short term, we usually will work with someone for about 3 months. Often caregivers will return to our care. We know that the caregiving journey has many ups and downs. And so certainly someone who may come to us initially and then leave our care is welcome to come back.
Very thoughtful and personalized care approach. What are some of the benefits that caregivers experience as a result of being in a program like yours?
They're so vast. Certainly for caregivers, we know that this support absolutely addresses mental health challenges, reduced anxiety, reduced depression, so improving one's mood, addressing any traumatic stress symptoms that could be present, just to say that caregiving can be traumatic. And I think giving space to caregivers to process these traumas is critical. We know that this type of support can help caregivers to feel more in control of caregiving. And that's important because most of us don't choose to become caregivers, right? This is a role that we are just thrown into, but this type of support can help folks to feel a sense of control and self-efficacy and to feel more prepared. And so there are certainly vast benefits for caregivers, and I should say benefits for patients as well. We know that when caregivers are getting this type of support, they are better able to take care of patients. And we actually know this support has led to lower use of emergency departments and generally leads to lower rehospitalization rates.
Terrific. I'd like to let the audience know now that they can enter any questions in the Q&A feature at the bottom of their screen. Hopefully they see that. We did have some people who have signed up for this Zoom send in some questions in advance. Let's see, what did we get? One question that came up was, what is the role of genetics? I'm not sure who would like to answer that here. George?
I can take that. So it's really interesting because Alzheimer's disease is highly heritable. The heritability of Alzheimer's disease is estimated to be 60 to 80%, which is really, really high. And yet, very few individuals would have a monogenic, which means you have a change in one gene causing your disease. These are autosomal dominant, inherited Alzheimer's subtypes, and they are, I don't know, 1,000 individuals, 1,000 families or so. It's very rare. So we have not actually gotten to the bottom of the heritability of Alzheimer's disease. And I think it's much more complex than just one gene. It's multiple genes. So some of the tools now in development are combining information from the entire genome of the individual. And still, we're not explaining a lot of the variants. This is good news because recent papers that have been fueled by, again, these biomarkers that are available to us that allow us to study Alzheimer's disease at scale. So the initial biomarkers were, again, cerebral spinal fluid or PET scans, and maybe you could do it in 500 individuals if you were lucky. But now you can actually do blood biomarkers on 500,000 individuals. And some of the data emerging are that there are modifiable risk factors. And for women, some of those risk factors are actually in midlife. So menopause is a risk factor. Diet, implementing Mediterranean diet is a risk factor. How do these lifestyle factors interact with someone's genome is another question that we're now equipped to start asking. Because when we looked at just the genome by itself, it's not explaining a lot of the variants. If you look at the lifestyle, it's noisy. It's actually very hard to quantify. But I think bringing these two together and using the blood biomarkers as a disease marker, as an index of disease, I think is going to lead to very powerful approaches to both preventing disease in individuals whose parents may have had disease or whose family has a high burden of disease, But I would actually argue that it could also slow down the disease process for individuals that are already affected. I think some other discoveries in the recent years have demonstrated that despite the fact that we cannot completely stop disease, we can slow things down. And we turn to drugs and pharmaceutical agents, but lifestyle goes a really, really long way. So the Allison Center for caregivers and patients is one kind of intervention that potentially changes the experience of living with disease for the patient and their environment. And I think we will have a lot more interventions in the years to come because we now have these tools. So you could intervene on sleep and ask, am I doing a potent intervention? Are the blood biomarkers changing? So I want to really emphasize that the blood biomarkers are not only going to serve as a diagnostic, but they're also going to give us readouts of interventions, which is really exciting.
So we have a question that just came in on the Q&A. Let me read it, and maybe Dr. Nissan can start off, and it looks like Allison will chime in as part of this. It's a two-part question. Will you be able to address the differences of FTD, that's frontotemporal dementia, versus Alzheimer's versus other dementias, and how they affect caregivers differently too?
So that's actually, yes, that's actually a great question. And we do have a lot of tools to clinically differentiate, these illnesses from each other, but also more and more emergence of biomarkers that can help us. So, for example, somebody with a degenerative disease can have Alzheimer's disease. That's the most common one that people know about, that people have read about. They understand, they know the name. But there are other conditions like Lewy body disease or dementia with Lewy body disease, frontotemporal dementia, which is really a term that refers to a group of illnesses that have some things in common, but also other things that diverge from each other, such as behavioral variant frontotemporal dementia, people that have personality changes and changes in their social decorum and emotional processing, empathy, so on and so forth. And then there's other parts of frontotemporal dementia that affect primarily language. We call them primary progressive aphasias. And even within that, the language, what's affected could be that the way that we produce language, meaning how do the muscles of our mouth and throat and tongue move together to produce language, and that could be affected. Or in a different disease, the knowledge of vocabulary of words, can be affected. And all of these are very different from each other. And we usually do pretty comprehensive evaluations at the Deane Center to differentiate these from each other through a combination of talking to the patient and their families about what are the symptoms, what have been going on, but also obtaining imaging in order to appreciate if there are specific parts of the brain that dictate these various different things. A part of the brain that the frontal lobe, for example, is affected more in behavior, but the back part of the brain is affected more in visual processing, so on and so forth. But also more recently, biomarkers such as the blood biomarkers we've been talking about for Alzheimer's disease. There are quite novel skin tests and spinal tap fluid markers for Lewy body disease, etc. So we're able to differentiate, that's, first and foremost. And then obviously, because of the differences of these illnesses, they confer a little bit of a different journey for the spouse or the son or the sibling, whoever is taking care of the patient or a friend. So the care partner, can have a very different journey depending on what the disease is. For example, people with Alzheimer's disease often retain emotional social processing. And while we might think of that as being something good, because they have memory problems and cognitive problems, they cannot put context to the social things. So they react very quickly to stuff that may not be that problematic. And so they are patients that could be more agitated or could have a lot of denial or delusions because they appropriately process the emotions of a wrongful context, if that makes sense. And that is one thing. As opposed to somebody with frontotemporal dementia, usually these people are very apathetic. They have a lack of motivation. They don't care enough about things happening around them, not because they don't care, but because that part of the brain is affected. And therefore, they're more or less more docile and at times in a weird way, even though it's a behavioral disease, that it could be easier to care for them because they don't get agitated because they don't care enough to get agitated. And then people with communication problems, that's its own sort of special sort of difficulty on the couple and the caregiver because the communication becomes affected. People may know what they want, but they can't say it. The spouse wants to help them, but they can't understand, so on and so forth. And maybe Allison, you and your group probably have seen some of the differences already, and I don't know if you can help us also with what caregivers go through when there are these differences.
Yeah, absolutely. That was a really, really beautiful description. When I think about the nuances of these different illnesses and diagnoses and spectrum of symptoms, I think about, quite frankly, the unique experience of caregivers of what we call pre-loss grief. Pre-loss grief is not anticipatory grief, which is I'm anticipating someone may not be here in the future, but it's the grief that we experience when we see changes in our loved ones, when our loved ones are no longer able to interact with us in the same way that they once did, engage meaningfully in conversations, make decisions the way they once did, or physically capable of doing the things they once did. And I think often what differentiates these conditions in terms of the caregiver experience is the rapidity with which those changes are occurring and the experience of that anticipatory grief over time. For example, that apathy that Dr. Nassan mentioned might be very, what we call in psychology terms, ego dystonic. It might be very unlike who that person has been for the duration of their life. And that personality change may be very, very disturbing. I think what these illnesses share in common, of course, over time are the neurocognitive changes that really put responsibilities on the shoulders of caregivers to eventually take control of healthcare communication and decision making. And so from our perspective in the Alzheimer Center, regardless of the flavor and the diagnosis, if there is a neurodegenerative disease, our work is really around the urgency of giving caregiver support around healthcare communication and making sure they're having conversations early on in the case that there is a progression of disease and their care partner may not be able to engage meaningfully in a short period of time.
Thanks, Allison. Here's a question that was sent in. What is the benefit of early diagnosis of cognitive decline and/or dementia? Will medication sooner than later make a difference in the speed of decline? And how to get a primary care physician to diagnose when appropriate? That's up for grabs. Dr. Chand, Dr. Nassan.
I'll take that. So I think I'll start with the back end of it first, and then go into the front, the beginning question. That for your primary care, I kind of serve as a primary care as well as consultant, so I kind of understand the perspectives of how busy it can really be to get the attention of the primary care provider when they're also trying to take care of your cancer screenings and their checklist of things to make sure your blood pressure is well controlled. I think one of the most important things to do is be prepared for your visit. If you have memory concerns, either for yourself or for your loved one, accompany them to the visit and really make sure that that concern is at least brought out at the beginning, and that would start a chain of events that begins with an evaluation, maybe a referral if your primary doesn't feel comfortable with doing this, maybe a referral to someone like Dr. Nassan to do an assessment. There are tools that are done by primary care doctors to screen if there really is a problem. But the first thing is to bring it to their attention. Don't leave it until the end as your visit is winding up to say, oh, and by the way, I have this question. Be prepared, be intentional, or even make a visit specifically to ask those questions. I think that's the way to get the attention and to get everything started. Related to diagnosing early, I think that's a really important question, because had you asked that 20 years ago, maybe 30 years ago, there may not be real benefit except for planning for the future, right? To be diagnosed. There were not treatments available. We didn't understand the pathology and how we might be able to impact earlier in disease. Certainly, there were no supports available for the caregivers during that journey. And so I think the answer from decades ago would have been, it probably doesn't make that much of a difference. Why know something when you can't do anything about it? It's incredibly different now. We have a much better understanding of the different kinds of dementias. And depending on the type of dementia, there are absolutely interventions that are available to either slow it down or to at least address some of those causes. And while there is no cure yet, I share Fanny's optimism that there may be things down the line and maybe in the very near future. So while there is no cure as of yet, there are many things that we can do to intervene. And certainly there are new medications that are available for the earliest stages of Alzheimer's dementia that were not here 5 years ago. So those would be the reasons, not that you would necessarily accept those therapies, but at least have the options and understand what's going on and anticipate and plan for the future, I think is incredibly important.
I think related to that question is another one that was sent in, and you touched on it very briefly, but have there been any new developments in early detection of Alzheimer's disease and early detection and treatment? So I think maybe mentioning the new treatments, the infusions, etc.
Early detection first. Do they want to hear about early detection? Did I hear that correctly?
New developments in early detection
Yeah.
of Alzheimer's disease and then new treatments.
Yeah, so
Dr. Nassau can both do that.
So the new development for early detection is blood. We are now moving almost fully to blood, to the point where I worry about the research a bit, because we needed the cerebrospinal fluid in order to develop new markers. It sort of served as the gold standard. But these blood biomarkers for Alzheimer's and brain degeneration, and I'll go into a little bit more detail what that means, are excellent. And as such, it really serves as the first starting point for the diagnosis. And we're still confirming with PET scan or CSF testing if the patient wants an anti-amyloid treatment. And we can talk about that more. I'll turn it maybe to Dr. Nassan to discuss the different kinds. But we're only doing that because they're new. And because the way that the trials were done and the way that the approval happened was through PET scans, because we know that these tests are really excellent. They are as good in classification as PET scans. None are perfect. Every so often, there are some errors, but so is the PET scan. No test is absolutely 100% of the time accurate, but this is really above 90% accuracy. So that's the revolution in early detection. And I want to follow that by saying that it's not going to be one marker. It's going to be panels of markers. And as we develop these and take them to clinic, which is what Mount Sinai, as one of the healthcare systems, is really invested in doing, we are going to become better and better at diagnosing early, but also at getting hints of etiology, which means why does someone actually have Alzheimer's disease or the synucleinopathies or FTD. And it's going to start pointing towards interventions that we wouldn't even have thought of. So early detection is really tied to what we intervene on and when we intervene on. And as it stands, we have the anti-amyloid treatments, which I don't know, George, if you want to talk a little bit about.
Sure. And this was alluded to both by Dr. Chan and Dr. Elahi. So in the past couple of years, we have new options for treatment for people with Alzheimer's disease in the form of what we call monoclonal antibody, which is a mouthful to say that it's basically a medication that the way it works is it goes into the brain and sort of tags the amyloid plaque, which is what forms in the brains of people with Alzheimer's disease. It tags it for elimination by our own immune system. So basically, the medication helps clear the plaque by turning our immune system against it and sort of removes it, in that way. And when it was tested in people with early Alzheimer's disease, meaning people with either mild symptoms, mild enough that they're not affecting their day-to-day lives, we call this mild cognitive impairment, or early dementia, meaning it's affecting their day-to-day life, but not in a very prominent way. And in these patients, it was demonstrated that that medication first of all, they were really good, these medications, at removing the plaques. And second, they delayed the progression of the symptoms over time compared to those who were receiving placebo. One of the caveat, unfortunately, is that the medication is risky. There's about a 20 to 32% chance of risk of bleeding or swelling inside the brain as a side effect to the medication, depending on which drug you use, because there are two of them with slightly different regimens and procedures. But people have been receiving this medication to some extent, and it's good to have that option, to offer, people. At Sinai, we currently have about 40 to 50 patients that are receiving this treatment. In some other institutions in other states, they could have, up to 100 patients or more. So people are receiving this. And we are seeing, the similar results to what we have seen in the research is that, for the people who don't get the side effect, there is a stabilization and a delay in the progression of the symptoms. And for some people, this is not helping as much. The progression continues, or they get the side effect that sort of precludes them from continuing the treatment. It's very complicated. It takes a lot of coordination, and we need a lot of people on the team to do this because there's monitoring with brain MRI that occurs at specific intervals. There is sort of monitoring of symptoms. We need to see them in follow-ups in a pretty frequent way. We have to repeat imaging to make sure that the plaques, are being removed. So all of this requires a lot of coordinated, effort that really needs sort of, to borrow something that Jane said that she borrowed. It takes a village, in order to make that happen.
But I think, George, just like the blood biomarker test, this has been a game changer. Agree?
Absolutely, absolutely. I mean, a few years ago,
It
the
was,
conversations we were having with patients who have Alzheimer's disease are very different from the conversation we are currently having with them about what their options are and sort of how to look at the treatment for this.
there's a new treatment. Exactly. Now, there's been a couple of questions that really overlap. Someone said, what are the red flags that indicate decision-making ability has been lost? What are the warning signs that mean finances should be handed over? To me, that falls under the heading of a third question, which is, how do you know when it's normal cognitive aging and when it's something else?
Blood biomarkers. Can I bring it back to blood biomarkers in part? I'll hand it off to someone else, but the second part of the blood biomarkers that we're doing that I didn't elaborate on are biomarkers of brain degeneration. So these are non-specific, which means any cause of brain degeneration, vascular, alpha-synucleinopathy, FTD kinds of pathology will elevate the levels. And so when someone has symptoms, whether it's psychiatric or neurodegenerative or other, these blood biomarkers can be incredibly helpful. And I think we'll have more.
Day to day, I think that no one's aware of their blood biomarker. I think this kind of question is really a clinical question about how do you know when, what is the red flag about decision making when it's impaired? When should finances be handed over? And when is it more than just normal aging?
Yeah, so I'll take that. I get this question all the time. Is this something that is normal or is this dementia? And we certainly know there are changes, there are physiologic changes with aging that we all have to accept. Our skin changes, our muscle mass changes, our kidney function changes with age, and there are things that are related to our cognition that do change with age and are considered normal and not Alzheimer's or another type of dementia. So one of the things that becomes very common is this kind of tip of the tongue phenomenon where you can see the actor that you want to talk about, all the movies that they're in, you can all do that, but the name is not coming to you. And then 15 minutes later, you say, it was Robert Redford. Now he's in the news. It's all coming into my brain. So that tip of the tongue can be very frustrating. And at the same time, it is something that we see with normal aging. The other thing that happens is that it becomes a lot harder to focus and to learn new information. So it's not that you cannot learn something new. It just means that there needs to be a lot more intention behind it, and it may take longer for you to learn something new. So I always use language as an example for this. You're 5 years old, and you can pick up 4 different languages and speak them fluently without any sort of accent, right? In your adolescence or your early 20s, you can learn new languages, maybe not quite as easily. You probably will still have an accent with those things. As you get into your 30s and 40s, yeah, you could still do it, but you're definitely noted not to be a native speaker, and it may take many more years to become, at a level of fluency. And with each decade of life, it becomes more difficult, but it does not mean you cannot learn a new language. So those sorts of things occur with normal aging. With dementia, when we know it's not normal aging is when there are really big personality changes that might be occurring, and that your day-to-day function starts becoming affected. So whether it's finances, whether it's the ability to drive, whether it's, being able to manage maybe the bills, or trying to figure out a new device, and learning, or being unable to learn all of those new things that come about. Those might be indicators that it is not just normal aging, but in fact a dementia, and really should be looked at before. Regardless of, none of us knows what our future holds. And so regardless, I always tell my patients and my own family members that it's really important to plan for the future. You don't know what's going to happen. So related to finances and thinking about how to plan for the future, I think that's an important part of everyone's kind of healthcare journey. Not only should you make decisions about who could speak for you and on your behalf if you were to become too ill to communicate what you wanted, you should also do that for finances, for caregiving, like what you would want, what you absolutely wouldn't want, where people can find passwords and access to different things. Even if you don't want to give it to them directly, at least to have a place to direct them should that need arise. But it's really difficult, because when you lose that decision-making capacity, you're not self-aware enough to understand that you've lost that decision-making capacity, and everyone else may see it, but you won't. And that can be one of the most challenging negotiations that need to take place between individuals. So I think that would also be added to the caregiver stress and navigation of trying to help someone who doesn't want to be helped, because the insight is lost. So again, I think that's a really important thing to discuss with your primary care doctor. If they don't feel comfortable with that, a referral to a neurologist, particularly a cognitive neurologist, about whether this is normal aging or not. Many times it is normal aging. So the vast majority of people are not being diagnosed with a dementia. It's oftentimes some normal change. So it can be very reassuring as well to have those visits.
I might add, Audrey, that I often ask a patient, is it worse than it was a year ago? So to see if there's a progression. And when we talk about bills, I also have found that to be a very sensitive area. It's usually the front part of our brain that's involved with, higher level functioning, complex tasks. People start to make mistakes, they pay late, they double bill, etc. If it's worse than it was a year ago, that's often a sign something might be going on, or call it a red flag. Would you agree?
Absolutely. That's a really important point, is that kind of having the larger perspective. A point in time of, misplacing your keys does not mean it's a problem, but misplacing things time and time again, and not being able to come up with a system to address that, and maybe that's an indicator, or if it's getting worse over time. And oftentimes the person is not aware. It's a reporting by other people around them who recognize that things have changed over time.
And that's often when a patient gets referred by Dr. Nassan, by Dr. Chun, by Elahi for neuropsych testing, just to have even a baseline of cognitive functioning in time. Is there memory decline? Is there a visual spatial decline, language, or front part of the brain, which is executive functioning, involved with planning and organization? So to have that, or are they worried well, which we all hope for. But I think that, we're all part of the puzzle and the piece to figure out what's going on. I think we have time for one more question. Let's see. There was something specific in the chat, I think, about FTD, so it's specific. Maybe this is Dr. Nassan. Is non-invasive brain stimulation being used for FTD or any other dementia?
There are some research, being done on aspects of this. People are studying transcranial magnetic, stimulation for things like apathy or, depression or, specific symptoms within dementias that may be symptoms, of FTD, such as apathy. It's not yet applied in a sort of widely accepted way clinically, and I think we still have a lot to learn about whether it helps and to what extent, and sort of what are the details of how to apply this in a clinical way. So I think there's more to discover there, but we're not doing it clinically in a systematic way. Let's put it that way.
Before we call on Dr. Chun to do some closing remarks, I just want to add, you can see we work as a team. Someone might start by coming for neuropsych testing. They might start with their geriatrician who refers them to neurology, to Dr. Nissan's group. He then refers to neuropsych testing, etc. They'll get a blood biomarker. And now there's clinical services for caregiver support program. But that is what's special here, that we work together in how to help a family and a patient navigate this disease. So I think we're up to Dr. Chun.
Yes. So I want to thank everyone who has joined this webinar. I hope that you've learned at least one thing new and maybe even more. I know that I certainly learn from my colleagues every time I interact with them, and certainly appreciate the innovative work in early detection through biomarkers and blood testing, as well as the support of caregivers. Really, Fanny and Allison, you give me great hope for the future of this field and what we can accomplish in working together in diagnosing early, finding those treatments, hopefully finding cure, and when we can't cure, supporting the entire dyad of caregiver and patient through that journey. So thank you for all of your work, and I really do have great hope for the future, and certainly for this center. I know that Mrs. Deane, so Mrs. Barbara Deane, Bobby, thank you. I want to give a special shout out to you and your family for having the vision and helping us to create the Deane Center, where so much of this exciting work has originated and will continue going on in the future. So thank you very, very much. And before we log off, I have an important final point to leave with all of you. All of the really clinical innovation that you've heard today and that we just discussed was possible because of extraordinary philanthropy. So the Elbaum Center that Allison mentioned came with very generous support, but they still need more. Fanny mentioned, Dr. Elahi mentioned the support of the Davos Foundation, but at the same time, it's not enough to do all the exciting things that we have the ability and the capability of doing, but we just need support for that. So this work has only just begun, and we need your help to keep these talented leaders and the resources that they need to keep going, so that we can keep innovating, providing care, and really being at the forefront in all the ways that we are so proud at Mount Sinai of providing. So there's a special QR code or a flow code for those of you who are aware of how to use that. It's on the screen now. You can just point your smartphone camera at it and it will take you to a web page if you are interested in supporting the work that we do. And I really appreciate your consideration. And certainly, whether or not you support us monetarily, we really appreciate the support that you've given us this evening in learning about the work that we're doing. We're happy to see anyone that you want to refer to us. And thank you again for your time this evening and your support.
Thank you. Thank you, everyone, for joining our panel and our guests.